late, just new to the online lecture series, so it was not as easy as I thought it was going to be, but here we are. And again, thanks for joining. I'm going to start sharing my slides. And by way of disclosure, I don't have any contracts with any medical companies. There are at some points in the talk that you will see medical companies listed because they make certain devices that help in the management of heart failure. But again, I don't receive any honorarium from these companies. So let's get started. Start slideshow. Okay, so what we're going to talk about today is an introduction to heart failure. It's on the epidemiology of heart failure, the incidence in the Western world, diagnosis, some of the questions that your physician may be asking you if they suspect that, and then we'll move into diagnostic modalities to prove that that's what it is, followed by treatments, and then we'll close with some of the more complex treatments, and then prevention. One quick slide on prevention. So the layout is first for the defining heart failure, then we're going to go to causes and kind of the big divisions. We'll touch on the prevalence and burden, the diagnostic modalities, treatments. We'll spend some slides on that, which are a little more heavy, and then the prevention. So what is heart failure? To define it in layman's terms would be a complex of symptoms that develop resulting from the buildup of blood within your heart chambers because the forward flow is reduced in some way. It can either be reduced because the squeeze of the heart is reduced, or because the heart is so stiff that it is impairing the filling of blood within the chamber. There is some kind of structural and functional impairment of the filling that results in the symptoms, but the cardinal symptom would be shortness of breath, which we call dyspnea. Here are some of the other symptoms that heart failure patients may experience: worsening fatigue, an inability to exercise based on their baseline, a non-productive cough, especially when laying down, a syndrome we call orthopnea, which is sleeping above one pillow at night to help with breathing comfortably, swelling in the ankles and the feet, having to urinate multiple times in the night, unintentional weight gain, cold hands and feet, abdominal bloating and swelling, and then an unexplained increase in the heart rate. So this female is noted to have some of the symptoms. She's experiencing heart pounding and racing, which is why she's holding her chest. And heart failure in and of itself can also cause chest pain. It doesn't mean that someone's having a heart attack per se, but the buildup of fluid and pressure within the heart chamber itself can cause the feeling of chest pain or chest tightness. She's also experiencing swollen ankles and feet, which in and of itself, again, don't necessarily point directly to heart failure alone, but it can be a constellation of symptoms that may trigger a cardiologist or a physician to start the diagnostic workup. So why does the patient with heart failure develop shortness of breath? What's happening is the blood is building up inside of the chamber that usually would pump to your body, your head, your other organs that are vital for you to function, such as your kidneys and liver. As the fluid builds up, pressure builds within inside the left ventricle and is transmitted to the chamber right above the left ventricle called the left atrium. It is the left atrium that usually receives blood from the lungs, and it's a very low pressure circuit. At this point, the pressure is usually somewhere in the range of 10 millimeters of mercury or below. Once the pressure goes above 12 millimeters of mercury, it is not transmitted forward into the left ventricle, but transmitted backward into the lower pressure chamber, which is the lung circuit. And unfortunately, as the pressure builds inside the pulmonary veins, which are bringing blood out of the lung, it starts to squeeze the fluid into the sacs that are usually used to oxygenate your blood. And we have another slide here showing the causes of pulmonary edema, where a normal capillary would be extremely thin-walled sacs, almost like a cluster of grapes, where air would enter and then slowly and passively go into red blood cells and be carried to your body to be used. When pulmonary edema is occurring in these sacs, oxygen can no longer be transmitted passively from the sac into the red blood cell and carried to the body. So oxygen circulating is lower, the body feels worse in a sense of fatigue. It may start with a different type of metabolism called anaerobic metabolism. And fluid can then be transmitted backwards from that spot into the pulmonary artery, which is where we usually measure it with a catheter, and be transmitted further backwards into the right side of the heart, and then into the veins that deliver blood into the right side of the heart. At that point, transmission further would result in things like distension of the veins of your neck or distension in the legs, creating the appearance of edema. This is an example on your right of a patient that has a normal chest x-ray. It is very black and clear because there is a lot of air within the lung space. The white spaces in the middle would be your heart, and that would be tissue that's reflecting the x-rays back. However, on your left, you can tell that there is a lot more lines of white stretching out of the lung fields. We would call these interstitial markings, and they appear in a bat wing configuration with some areas that are very more prominent than others, especially in the middle. And this is actually fluid. And if you notice on the one on the left, the chest x-ray shows in the far left, which is actually the patient's right, there's some fluid building up in the space between the right upper lobe and the right middle lobe, which we call the fissure. Sometimes the patient can even have fluid within the bottoms of the lungs, which we call pleural effusions. It is the space between your lung, the diaphragm, and the chest wall. So there are certain symptoms that occur with left heart failure and certain symptoms that occur with only right heart failure. The most common cause of right heart failure is left heart failure. So because you see edema and elevated veins in the neck or distended veins in the neck does not necessarily mean that it's only right heart failure. However, we do have patients that have isolated right heart failure that would only have increased swelling in the legs, the veins of the neck, and the liver, and absolutely not have fluid within the lung space. The patients will still feel fatigued due to the buildup of fluid, but the oxygenation may be unhindered. So the effect can usually be thought of as distributed to these dependent organs and then sparing the lungs in this situation. The abdomen itself may become enlarged and distended, and the patient may feel full after only a very small portion of a meal. The patient's men can also develop swelling of the scrotum, and there can be pain in the right upper quadrant due to swelling and congestion within the liver. Doctors and the medical system in general may talk about symptoms of heart failure patients in a classification scale that is historic and referred to as the New York Heart Association classification. This is a very easy way to discuss a patient's current symptom with another physician, a mid-level provider, or a medical assistant that will be very quickly interpreted as mild, moderate, or severe. It's also useful when classifying patients with respect to what kind of therapies they will need or they may qualify for. But this may be written on the chart that you see as NYHA1 or NYHA2 with the Roman numerals beside of it. As you can see, when you move from class 1 to class 2, you develop symptoms. Class 1 would be patients that may have risk factors for heart failure but have no symptoms. Maybe they've had a prior heart attack. Maybe they have sleep disordered breathing, but they have no shortness of breath with activity. They have no shortness of breath when lying down. They do not have increased abdominal girth. And then as you move up the scale to class 3, there becomes a marked limitation of physical activity. Some specialists will further classify class 3 into class 3A and class 3B. And class 3B is usually a worsened type of limitation in activity. The biggest divisions of heart failure that I wanted you to take away from the talk are systolic heart failure and diastolic heart failure. This is a very common nomenclature used by physicians, mid-level providers, medical staff, and medical billing. And it determines a lot about which patients would get which therapies. Most of the therapies we have currently are very well established as beneficial for systolic heart failure. However, the data that they are beneficial for diastolic heart failure is very much lacking. So systolic heart failure would be very clearly defined as a reduced left ventricular function or left ventricular ejection fraction, which we refer to as the squeeze of the heart, below 40%. Normal for a female would be 52% or above, and for a man would be 53% or above. Diastolic heart failure is normal function where the patient would have symptoms, but then have an ejection fraction greater than 50%. There is a mid-range, and in the last 5 to 7 years, more attention has been paid to this mid-range of heart failure as we try to tease out what therapies were beneficial for what number of function that we're seeing on imaging studies. And then we have patients too that have recovered. So that is a newer terminology in the last 5 to 7 years, heart failure with recovered ejection fraction, which we hope everybody with systolic heart failure will eventually achieve with good medical therapy. Here is a distribution of the percentage of patients with heart failure based on their gender and the percentage of function. As you can see, there is a slightly more amount of systolic heart failure or HFrEF patients in general, something on the range of 50 to 55%. There is, however, a growing number of heart failure with preserved function patients, and it seems to be more common in women, especially women that have more risk factors or what we refer to as comorbidities, such as hypertension, diabetes, sleep disordered breathing, and sedentary activity. The prevalence of heart failure in our society is growing very quickly. Unfortunately, it seems to be following our obesity epidemic. In 2018, a little over 6 million adults were living with heart failure. And as you can see, it grows quite quickly when we go above the age of 60 into our Medicare population. The growing number of patients seems to indicate that our baby boom population is getting to this age group and starting to have chronic medical illnesses. So you also will notice that women tend to catch up very quickly to men somewhere after the age of 70. This is likely due to a protective part of the menstrual cycle. And once it's gone, women tend to catch up with men with respect to the risk of coronary artery disease and heart failure. Women tend to have more comorbidities that would lead to heart failure. However, once the heart failure is diagnosed, women tend to live longer with heart failure. This is a distribution of the hospitalizations in America from 2000 to 2010, and it's looking at only the heart failure admissions during that time period. So as you can tell, the number of patients from the age of 65 and over that were hospitalized for heart failure shrunk from 2000 to 2010. And we'd like to think that's due to the medical therapy that patients are getting and the quality of care that patients are getting. However, if you look, there may be just a slight shift in the population scale in patients under the age of 65, and we may see a catch-up phenomenon coming in the 2020 distribution. So we'll have to wait to see what that is, but you can tell here that the largest percentage of patients that are admitted with heart failure tend to be our elderly patients over the age of 75. And that will probably again hold. There will probably be fewer patients under the age of 65. But again, we'll wait to see what the next data looks like. Our rate of heart failure admissions tends to be higher than the rest of the world. We also have a higher burden of ischemic heart disease than much of the world, and a higher level of obesity. So this may be following that, but you can tell that we run with Germany and some of the Scandinavian countries, whereas the Japan and the United Kingdom tend to have a better hospitalization rate for heart failure. So just to summarize, there's quite a bit of burden on the medical system from heart failure hospitalizations, which is why there's a large focus on trying to prevent readmissions within 30 days by insurance payers. Overall, the cardiovascular mortality is dropping. I think we are leveling off, as you can see, in 2013, 2014. And I think that's due to improved access to medications, as well as improved knowledge of the backbone of heart failure therapy, how to treat from the beginning and before discharge from the hospital. So we're going to go over now the causes of heart failure. And the number one cause of heart failure in the United States is coronary artery disease and subsequent myocardial infarction. Very close to that, though, would be uncontrolled hypertension. There is a large portion of society with heart failure that has it due to inherited conditions. Specifically, dilated cardiomyopathy is the most common inherited cardiomyopathy. Hypertrophic cardiomyopathy is a disease where the patient has extremely thick heart and usually a preserved function. So this is our classic heart failure preserved ejection fraction patient. And in the end, many patients will go on to develop heart failure with reduced ejection fraction without good therapy. Fabry's disease is an inherited disease that causes both kidney damage and heart failure. Heart failure can also be caused by valvular abnormalities, either regurgitation, which is leakage of the valve, or blockage of the valve, which we refer to as stenosis. Typical in the 80+ year population, the most common reason for stenosis would be aortic stenosis. Heart failure can also be caused by viral infections, myocarditis, which is a very severe inflammation in the myocardium, or the heart. The actual heart muscle itself can be sometimes picked up on a cardiac MRI. In the Central American countries, there is also a parasite that can cause heart failure if it is allowed to circulate through the body. There are some autoimmune causes of heart failure, specifically sarcoidosis, which causes areas in the heart to become inflamed and then granulomas to form within the heart. Systemic sclerosis can also cause an infiltrative heart abnormality. Another infiltrative heart condition that has been well studied in the last 10 to 15 years is amyloid cardiomyopathy. There is a phenomenon of radiation-induced cardiomyopathy in patients that have prior history of radiation from mantle cell lymphoma or breast cancer or other type of cancers in the lower neck and upper chest area. And then a common phenomenon that's been described is stress-induced cardiomyopathy, which was first described in Japan. And so the medical terminology sometimes will call it Takotsubo cardiomyopathy. So how do we diagnose heart failure as clinicians? It starts with listening to the patient's history and their story. We then move to the examination of the patient, and we're looking for certain signs that may be more sensitive and specific than the story alone. Lab testing can also be essential in helping rule out or rule in heart failure, especially in the emergency setting. Echocardiography is probably the most sensitive and efficient way of diagnosing heart failure. Nuclear cardiology is the use of radioactive tracers that are injected into the body and pictures that can show function as well as blood flow in the heart area. Magnetic resonance imaging is another modality that does not involve radiation and is safe. It uses magnetic fields to change the way water behaves within inside the cells of our chest and determine the heart function. It is very sensitive, and we'll review that too. Cardiac catheterization is another essential tool that we use to rule out the presence of coronary artery disease and sometimes help open blocked arteries and improve the heart function in that way. The problem with history, examination, and lab testing is that sometimes it's not very sensitive. So we must usually combine this with some sort of imaging modality. So a good physician is likely to ask you about your breathing when you lie down, again called orthopnea. They might ask you how far can you walk before you become short of breath or have to stop. This is important in the initial appointment and important in subsequent appointments when we're gauging how successful our therapy is. We might ask you to weigh in at every single appointment to gauge how we're doing with your volume. We'll ask you about swelling, specifically in your feet, your hands, and your abdomen. At the index appointment, we may ask you about your family history because heart failure does run in some families. We may ask you about any family history of heart disease and heart attacks. We may ask you about a family history of enlarged heart. They also may ask you about a family history of sudden deaths or unexplained deaths. Now, the clinical exam is very important, especially in the index visit to establish the baseline. Here, the physician is having the patient sit at 90 degrees while they examine the neck. And they're noticing that inside the jugular veins, there is distension of fluid. And this is due to poor forward flow with eventually backing up of blood within the veins that usually drain into the heart space. So it's a very nice tool to determine if the patient's volume status is currently very high. Auscultation, or the use of the stethoscope to listen to the heart and the lungs, is also essential. A good physician should listen to your heart and your lungs to establish a baseline and to pick up on any new findings. They may say they hear crackles, which are sandpaper-like sounds within your lungs due to fluid within the lung space. That's also referred to as rales by some physicians. They may note tachypnea in their notes, which is just fast breathing or a respiratory rate greater than 20. They may say that there's different cycles of breathing, which is concerning. That's called Cheyne-Stokes breathing and is a very poor harbinger of heart failure severity. They may note different heart murmurs, either systolic or diastolic heart murmur inside the cardiac cycle. They may also note the presence of a gallop, which is a third or fourth heart sound beyond the two heart sounds that are normal. And then they may say things like the patient appears tachycardic or hyperdynamic, which is considered just fast beating. Now, in the last 20 years, the use of the brain natriuretic peptide has changed our ability to rule in and rule out heart failure patients in the emergency department with very good sensitivity and specificity. So it's going to be useful with a patient that comes in with no history of cardiac disease and complains of shortness of breath. A patient with significant systolic heart failure should have a very elevated BNP, sometimes within thousands range. And a negative predictive value for BNP of less than 100 is quite good at 89%, which means you can reliably tell the patient that this is not coming from your heart and move on to other organ systems such as the lungs and the, possible thyroid, things of that nature. Pro-BNP levels are also in use in hospitals, even within this area, and it is a little more sensitive than the BNP test. So there are occasional false positives with obese patients and patients with diastolic heart failure, which is heart failure with normal function. And recently, we've now started to use BNPs on a chronic basis in the outpatient sector to monitor the patient over a period of time. It helps prognostically determine how the patient's doing. So again, labs can be used to help know the amount of congestion. Some less sensitive markers will be markers of kidney function, such as the creatinine level. Creatinine is a protein that is usually cleared from the blood because it's a byproduct of metabolism, and it usually is cleared by the kidneys. Urea is also cleared by the kidneys, and we can measure these on a lab value to see if the kidney is actually getting a good amount of blood flow. There can be an increase in liver enzymes due to congestion in the liver from fluid within the veins. And you can also find decreases in serum sodium level. This can be due to heart failure in and of itself, or the use of diuretics to treat heart failure. Also, the increase in fluid can cause low red blood cell counts over a period of time, and that's purely dilutional. Heart failure in and of itself can also cause anemia. So we must tease out which patients have dilutional low blood counts and which ones have true anemia, and then treat the ones that have true anemia. So moving on to diagnostic modalities. Again, echocardiogram is still the most sensitive, most efficient, and painless type of testing modality for heart failure. There is no radiation involved, and it's a very good quality assessment of both the valves and the function of the heart. It's fairly good at measuring pressures inside the heart chambers using such techniques called Doppler assessment. We also use a technique called color Doppler to mark the flow of blood into and out of the heart. The variability between different readers is actually fairly good when the heart function is normal or very low. In the range of 30 to 50%, there is a little more variability between different echo readers. Cardiac MRI is an exquisitely sensitive tool for helping determine cause of heart failure. And again, it uses magnetic fields and measures the way water responds to the magnetic fields within the tissue. And it uses this to actually create images. It is very useful to tell if the patient has an abnormality of function due to a prior heart attack that may have destroyed part or all of the muscle tissue. It is very useful to tell if there's infiltration in the heart muscle from things like amyloidosis or sarcoidosis. And it's also useful to tell if the patient has had a recent viral myocarditis, which all have different types of patterns. It is useful to tell if the pericardium or the sac around the heart is thickened and can actually be measured. Patients get inflammation of the sac around the heart, termed pericarditis, which can cause extreme thickening of the sac. It is limited by the use of gadolinium agents with patients that don't have good kidney function. And some of the older pacemaker and defibrillator devices will preclude the use of this in some patients. Recent joint replacements should not have MRIs, but after a certain length of time can be done. It is also difficult for some patients with severe claustrophobia, and you may want to consider either medicating the patient for this type of imaging modality or not using this type of imaging modality. Nuclear cardiology, again, involves exposure to radiation. So in the past, in the last probably 20 to 25 years, it was common to use thallium injections for stress testing. Recently, because of the better quality of images and faster washout of the radioactive tracer, there has been a move to technetium. That has been in the last 10 years. So if the patient can exercise, we always prefer that because then we get to see their functional status. But for certain patients, we understand that they can't exercise due to limitations, either joint or due to heart rhythm problems. And we can give those patients a medication that dilates the arteries around the heart called regadenoson. And nuclear cardiology does provide a good assessment of the left ventricular function and assessment of certain areas receiving blood flow or not. We usually compare the pictures from rest to the ones that are done after stress to see if there are differences. Differences can be either fixed, which means they appear black on both images, or reversible, where on the resting image, they are not apparent, and then on the stress images, we see an abnormality. The picture that I've included here shows a completely normal study where on both rest and stress, the patient has very good uptake of the radioactive tracer and normal distribution. The study can take anywhere from 2.5 hours to 48 hours, depending on the weight of the patient and the quality of the machine. However, newer cameras that use CZT technology can take a picture within probably 30 minutes or less. Cardiac catheterization is a well established and an essential tool in cardiology. And it's a definitive way to assess for coronary artery disease or any coronary anomalies in patients with reduced left ventricular function. Before the use of coronary CT, nuclear cardiology, and cardiac MRI, this was the only way to determine if the patient had coronary artery disease or not. So what happens in this is the patient is brought to an operation suite in a fasting state and is given a very small amount of sedation, then using either the femoral artery in the groin area or the radial artery in the wrist. The patient has a sheath placed that allows the operator to go in and out of that artery without bleeding from the artery. So it's a bloodless field. The catheters are about the size of a number 2 pencil, and they traverse the course of the artery up to the heart. Once it's there, it is hooked up to an injector that has contrast dye, and the contrast is pushed out of the catheter into the arteries around the heart, and x-rays are taken. X-rays usually are taken anywhere from 10 frames a minute up to 18 frames per minute. Per second, to gather images on an image intensifier. It is also an essential way to determine the pressure within the heart, and this can be done from either side of the heart. You can measure the pressures into the right chamber, and then using injections of saline, you can determine the actual cardiac function, which we call the cardiac output. And this is another essential tool to follow the progress of the patient over time. The drawback of cardiac catheterization is there is a small but statistically real risk of bleeding, infection, hematomas or blood under the skin, changes in the heart rhythm, stroke, and dissection of the heart artery. Very rarely now do we see de novo reactions to contrast dye. However, it does occur, and the patients can be pre-medicated prior to the procedure. We can also combine right heart catheterization with biopsy. This has become less frequent now that cardiac MRI has become more widely available, because we are able to see such good detail in the actual musculature of the heart that we usually don't need it. However, endomyocardial biopsy remains essential in the realm of advanced heart failure, where occasionally biopsies are needed to follow heart transplants. Now we're going to move on to treatments, and I'm not going to belabor this. I'm going to try to move through this more quickly, but treatments are very strongly proven in large-scale randomized studies for patients with heart failure and reduced ejection fraction. It definitely involves medication. That is something that you have to get used to have a pure functional life and good quality of life when living with heart failure. Another treatment is revascularization, which we mentioned before, can open up clogged or blocked arteries, or possibly through surgery bypass the artery. Cardiac rehabilitation is an essential tool that we use once the patient is stabilized and in the outpatient sector. And it's really supervised exercise. Basically, the patient's heart rate, blood pressure, and EKG are monitored while they're exercising in a graded fashion. The patient can help us with restricting their dietary sodium intake, avoiding the overuse of non-steroidal anti-inflammatories, which would be Motrin, Aleve, ibuprofen, BC powder, Goody powder, things of that nature. These tend to make diuretics less effective at the level of the kidney. So it's helpful if the patient lets us know if they need to use those for joint aches and pains or headaches. In cancer treatments, actually, sometimes just stopping the chemotherapy alone can help. And that's why this is a burgeoning field of medicine, cardio-oncology. The treatment of sleep disordered breathing has shown great promise in the improvement of heart failure symptoms and the improvement of the function of the heart. Occasionally, patients progress to the point where we need to consider putting a specialized pacemaker on both chambers of the heart that helps resynchronize the function of the heart. And then advanced therapies would include ventricular pumps or assist devices that are either implanted in the arteries of the heart or through a chest incision. And finally, would be heart transplantation. Beta blockers are one of the most essential tools and historical tools that cardiologists have, going back to the use of nacibutolol and propranolol. So the body's response to poor blood flow is actually to increase the central nervous system or the sympathetic nervous system activity. And so you will have a higher heart rate on a chronic level. And what we seek to do here is lower the heart rate and give the patient more time in the squeezing phase of the heart, and then allow the heart time to rest and strengthen. There are 3 medications that are absolutely well established to be effective in improving function and preventing cardiac death from heart failure. This would be bisoprolol, metoprolol succinate, and carvedilol. Other beta blockers are useful and just not as well studied. The only beta blocker that has been shown to be detrimental in heart failure is propranolol. So just because the other beta blockers don't appear here doesn't necessarily mean that they will worsen heart failure. They just have not been as well studied. You will find that these 3 medicines, though, with specifically noting carvedilol, are the most common used in heart failure. About 10 to 15% of patients with chronic heart failure are not going to tolerate beta blockers. So some of the side effects they have are impotence, fatigue, worsening asthma, and then significant bradycardia. So that's where advanced heart failure may be very useful for physicians. Diuretics are another extremely important tool to the treatment of both acute and chronic heart failure. There are many types of diuretics, but they all pretty much have the same goal. They want to remove fluid by helping patients urinate. Unfortunately, this is a side effect that patients, routinely complain of, but have to deal with. So we try to make amends as cardiologists by helping them with certain times of the day dosing to improve, the overall fluid balance, but then to prevent insomnia and to allow them to live functional lives. The loop diuretics are Lasix or furosemide, Bumex or bumetanide, and Demodex or torsemide. Lasix is probably the most common one you would see in the outpatient world. Unfortunately, Lasix has the least bioavailability, which means it's the least amount absorbed and then useful within the circulating blood flow. Thiazide diuretics are commonly used not only to treat blood pressure, but also to treat more late stages of heart failure. Chlorthalidone is a very old diuretic. Hydrochlorothiazide also is a very old diuretic. And metolazone is routinely used in more advanced heart failure cases when the loop diuretics become, not enough. Some specialized diuretic have come out in the last 20 years would be potassium sparing diuretics. And they work by increasing salt excretion, but they don't cause the loss of potassium. So when used in combination with either thiazide or loop diuretics, we tend to balance out some of the electrolyte abnormalities that would occur. These would be triamterene and amiluride. Another group that's very common in heart failure is the mineralocorticoid receptor antagonists, which are also called MRAs. They cause retention of salt and water, but they increase the release of potassium and hydrogen ions in the urine. So the one that probably most commonly seen in the outpatient world is aldactone or spironolactone. And you may commonly see spironolactone used in combination with torsemide or furosemide, which is Lasix. Now, the probably most essential part of treating heart failure is the ACE inhibitor. The evidence is overwhelming and unarguable when reviewing the literature of ACE inhibitors. They help with all types of heart failure, despite what the person may have, especially in patients that the function is lower than 40%. However, most cardiologists will have even patients with heart failure and preserved ejection fraction on either an ACE inhibitor or an angiotensin receptor blocker. Now, this is one of those moments in medicine that was from ground breaking research. So what was discovered was that the heart failure itself was causing a feedback loop through the kidney, which resulted in worsening heart failure. And when the kidney perceives that it's not getting enough blood flow, an enzyme is released from the kidney called renin. And unfortunately, the feedback will cause increases in blood pressure itself, thus worsening sometimes the pressure within the heart. It also causes some remodeling inside the heart muscle that is damaging. And it's particularly with the term called fibrosis. So the idea was if we could prevent and inhibit this renin angiotensin aldosterone system at different levels, we can help prevent this vicious cycle where heart failure begets heart failure. So again, ACE inhibitors will prevent remodeling of the heart. They improve the symptoms, they prevent hospitalizations, and they prolong life. Here's a picture of the renin-angiotensin system. I'm not going to go over it, but you can see how the medications have specific sites that they work at, that they inhibit to help block this cycle. Some of the more common ACE inhibitors would be lisinopril and captopril, fasinopril, quinapril, and ramipril are also available. You might see lisinopril and fasinopril used commonly to treat heart failure because it's one of our first line agents for the treatment of heart failure, for hypertension. Very close to the angiotensin converting enzyme inhibitors, the ACE inhibitors, is the angiotensin receptor blockers. So ACE inhibitors are usually first line, but studies have shown that these angiotensin receptor blockers, which we sometimes call ARBs, do provide a significant benefit and a reduction in hospital stays and mortality related to heart failure. They are also better tolerated than ACE inhibitors. The medications that you may see would be valsartan, candesartan, and losartan. Losartan and valsartan, as well as a different angiotensin receptor blocker called olmesartan, are also used to treat hypertension. The side effects of ACE inhibitors and ARBs would be a dry cough, high potassium levels, and swelling of the lips and face, which we term angioedema. It is recommended that whenever you initiate ACE inhibitors, angiotensin blockers, that you get a basic metabolic panel or electrolyte panel 1 to 2 weeks after starting to ensure that the patient continues to have normal to just slightly elevated kidney function from their baseline, and then normal potassium levels. So just to make sure we recap, the ACE inhibitor still would be first line. Usually a cardiologist is going to start an ACE inhibitor before an angiotensin receptor blocker. When an angiotensin receptor blocker started first, there's usually a reason. Maybe the cardiologist or the physician doesn't think the patient's blood pressure would tolerate an ACE inhibitor. Maybe they have a history of a side effect to ACE inhibitors, etc. The newest medication that's available and widespread now is an angiotensin receptor blocker neprilysin inhibitor, which is also called Entresto. You may have seen this on TV. There was a landmark trial in 2015 called Paradigm that compared the use of angiotensin receptor blocker to this novel drug, which is the combination of an angiotensin receptor blocker and sacubitril. And so they compared this head-to-head with enalapril and found that it actually reduced the amount of heart failure readmissions and had a slight reduction in mortality. Since that time, the use of this medication Entresto has grown rapidly. When you are initiating this medicine, it is required to stop the ACE inhibitor or angiotensin receptor blocker at least 48 hours to 72 hours prior to starting the medicine. Unfortunately, this medicine is still quite expensive and on patent. Usually insurance companies will require a prior authorization from the cardiologist before they would fill it. So again, if it's the first heart failure event in a hospital, the cardiologist may actually initiate this first line without ever having the patient on an ACE inhibitor or an angiotensin receptor blocker before. However, if it's done in the outpatient world, there will be at least a 2-day time period that the physician would ask you to stop your ACE inhibitor or angiotensin receptor blocker. So more advanced therapies would be resynchronization therapy. And this involves the use of pacing wires to help the heart function itself. Usually, the pacing wires are implanted first into the subclavian vein, which is in the top left or the top right of the chest. Most commonly, the pulse generator is placed in the top left of the chest. As you can see here, the leads extend from the generator and go into the vein and down into the heart itself. And one would be inserted into the right pumping chamber called the right ventricle, while another one would go into the vein that actually drains the heart, which we call the coronary sinus. And this one is actually behind the left pumping chamber, and it helps pace the left pumping chamber. The point, again, of this is to help the heart function be in synchrony. So as you can see on the chest x-ray, one lead coming out of the pacemaker bundle leads is going to the back of the heart, and that's going to the coronary sinus, which is the vein that drains the heart. The one lead that's going towards the front of the chest are directed to probably 10 to 11 o'clock, is the lead going to the right atrium, while the lead going straight down to 6 o'clock is the right ventricle pacing lead. Another device that's become more popular in probably the last 7 to 8 years is the use of a pulmonary pressure monitor. So somebody had the idea that some of the pressure monitors that are used in industrial mechanics, such as on airplanes to monitor for instability in engines, could be used inside the pulmonary artery to determine what the pressure in this area is. So this can be implanted through the vein in a patient's neck into the pulmonary artery and can constantly send signals to a monitoring station. Again, I do not receive any honorarium from Abbott, but it is a useful tool if you have a team of mid-levels and cardiologists that are willing to put the time in to give feedback to the patient. You can imagine that basically if you see the pressure going above a set point, the patient can then be told ahead of time to prevent significant symptoms and possibly admission by finding out if the patient is possibly not taking the right medication, not taking enough medication, or run out of medication. Or maybe the patient is not being very diligent about their diet. Mechanical circulatory support is much more technically involved, and it needs to be done inside of a hospital setting. Sorry, I'm just going to shut the door because the cleaning service was here cleaning. There's percutaneous models that can be implanted inside of a cath lab through the large artery of the body, and they work by pumping during diastole, or the relaxation phase of the heart. The blood is pumped back into the heart arteries to help with blood flow. This is called an intra-aortic balloon pump and has been around for probably 35 years or so. There's a more modern pump that has been around for the last 6 to 8 years called an Impella pump that can be placed inside of the catheterization lab for the treatment of acute cardiogenic shock. And basically what it uses is a rotary motor within a shaft that brings blood out of the pumping chamber and ejects it into the large tube carrying blood away from the heart, or the aorta. There are many types of Impellas, some bigger than others, and some giving more blood flow to the actual body than others. This is a picture on your left under the A area of an intra-aortic balloon pump. The balloon pump will inflate and deflate using the cardiac cycle. And the point is to inflate during the relaxation phase in order to push blood back into the heart arteries and improve blood flow. So in patients that are having heart attacks and significant chest pain or heart failure afterwards, this may be a useful tool. Also can be useful in patients that have had CAS, heart catheterizations, and they're awaiting bypass surgery. Under the term B is a picture of what we consider an Impella pump. You'll see the tiny little pigtail dipping into the left pumping chamber, which appears red, and then a black arrow, which shows where the actual blood would be ejected. And then on your right is a picture of the Impella pump. And you can see that there's a rotary inlet that looks almost clear with lines that is coming out of the blue part of this device, followed by a gray part, which is actually the inner cannula and a chamber that is used to pump blow up to the outlet area. So for more advanced heart failure patients, sometimes what's needed is an assist device, and these can be a more long-term answer to chronic severe heart failure. Patients need to be good candidates for the device as far as being reliable to take certain blood thinners to prevent strokes. They also need to qualify based on certain things such as not having end-stage cancer, etc. But the pump can be placed through surgical incisions over the chest. And the devices have gone through upgrades in the last 10 to 15 years. So each device has become smaller and more durable. The devices also have been improved to lessen the stroke risk. However, all the devices that I'm aware of still need the use of blood thinners at this point in time. Patients can have the device placed as a bridge to get to heart transplant or as destination therapy alone in some tertiary centers. Now, let's touch a little bit on prevention of heart failure. So the most important thing is that you remember to be active as you can be. I know some patients have significant arthritic and immunologic problems, but we need to encourage activity in any form. Yoga, Tai Chi, resistance bands, anything that gets your heart pumping a little bit more is good for your heart. The three biggest risk factors, which we have in abundance, unfortunately, in America, are uncontrolled hypertension, obesity, which also can be considered sedentary lifestyle, and smoking. One of the biggest things that we have as an initiative in cardiology is the Million Hearts Initiative. And I encourage you to go to the Million Hearts website or the American College of Cardiology or the American Heart Association to learn more about what you can do as a patient to not only contribute to bringing this message to Americans that may not even be literate, but also to participate and show that you are interested and that others should be interested. So every year, the American Heart Association sponsors heart walks in every city in America. And it's a way that you can show that you think it's important that Americans get active and care about their heart care. We have an aging population at this point in time that we're planning to take good care of. But one of the things that we need them to do is to maintain that dedication to be active. We need them to get out 3 to 4 times a week for 30 minutes and be active in some way. We also need people to be committed to going to see their primary care physicians on a regular basis and get screened for hypertension. Hypertension is called the silent killer because you have no idea most of the time that it's going on. So a visit to your primary care provider on an annual basis can help diagnose and treat something that you are not aware of. And finally, smoking. So the two biggest killers in America are heart disease and cancer. And smoking obviously can help, increase the rate of both. So if you think about the benefits of smoking cessation, it's not only related to your heart, but also related to the decreased chance of emphysema, COPD, and lung cancer. So with that, I'm going to stop and I'm going to let the moderator take over, and then I'll take questions.
Thank you, Dr. Foster, for that great and informative talk. We do have a couple of questions that are ready for you, and I will take the questions that I see here in the Q&A section, and I will go over to the chat. The first one is, what is the difference between heart failure and a heart attack? Once one has had a heart attack, does he then have heart failure? So 2 questions in one.
Okay, that's an excellent question, Kim. So yes, there is a difference. It is absolutely possible to have a heart attack and not have heart failure. So a heart attack is simply destruction of the heart muscle due to poor blood flow within the coronary artery. We know that a heart attack can be detected on an EKG initially, like in the acute phase, but also with lab markers. And we can see stunning of the heart muscle from a heart attack. However, because of the advent of primary intervention, which is revascularization or opening of the artery, we have managed to create an initiative in America that has led to a decrease in the overall mortality from heart attacks. We have something called a door to balloon time, and a person with an acute heart attack is rushed from the first medical contact to the cath lab so we can open up the artery as quickly as possible. That usually results in very little damage to the heart long term. So it is extremely possible that someone may have a function of 40% after a front wall or anterior heart attack, and with revascularization or opening of the artery and medical therapy, will never have heart failure. So yes, it's possible, and they are two different subjects. I will say that after a heart attack, if the function has been assessed and they see that it is below a certain number, which let's say 40%, the patients usually would be treated with the same type of medicine for heart failure. However, long term, the patient may be taken off of that medicine after a year or so, and then the heart function will be monitored.
Okay, great, thank you. Next question is, I passed a recent nuclear stress test, but experience upper chest tightness when walking fast or uphill. It goes away after 5 to 10 minutes. What test should I get? Lung, chest, or cardio?
So I'm imagining somebody that's walking uphill and is feeling, chest tightness, and is probably over the age of 50. I don't know if the patient or if this person was willing to share their age or anything like that. That's okay. But really, a nuclear stress test is extremely good at picking up any severe blockages within the heart arteries. So you may have a 40% blockage that's in the heart artery that a nuclear stress test is not going to pick up because it's not flow limiting. If I were that patient's cardiologist, I think what I'd be encouraging is we make sure that certain things are under control, like blood pressure. I would make sure that the patient has had a function assessment. So while she's telling me that her nuclear stress test is normal, is the function of her heart normal, or the squeeze or the ejection fraction? Because it's very possible that someone would have a normal function in a normal stress test, but could still have disease of the heart from hypertension or thickening of the heart muscle.
Okay.
If I would ask whoever the patient's physician is, can I just make sure that my function was normal on the echo? And if that is the case, then I would proceed to see a lung specialist to inquire about pulmonary function testing, which is a way to assess the strength of the lungs and how they function under their own stress.
Okay, great. And she also did share in the Q&A that she's 75, but she's fit. So
that's good. So I think I still would I would ask the question about the function based on the nuclear study and an echo. Is the function of her heart okay? The valve okay? Then proceed to the pulmonary or lung workup.
Okay, great. Thank you. Next question, how is AFib related to heart failure?
Yeah, this is a good question. So rhythm changes in the heart alone can result in heart failure. We usually see worsening heart failure patients with atrial fibrillation, you know, in the office, I think that's not a super common phenomenon, but it definitely happens. We also see patients that have the heart failure because of atrial fibrillation. For instance, a patient that has acute onset chest pain, palpitations, and then comes into the emergency department or comes into the office. Sometimes the acute insult of atrial fibrillation and the fast beating is enough to weaken the heart. So I try to take those patients and give them a little equipoise to remember that it may be only because of atrial fibrillation. And once we control the atrial fibrillation, it's completely possible that your heart function comes back up to normal, okay? More challenging is the patient that's had chronic heart failure and then goes on to have atrial fibrillation late in the game, or continues to have very resistant atrial fibrillation despite our efforts. That makes heart failure much more difficult to treat. And usually in that respect, we have to involve specialists from the electrophysiology cardiology department. We may consider, in the last 2 years, there have been quite a bit of advances in our knowledge about what can the treatment of atrial fibrillation do for patients that are living with heart failure. And it seems that the more symptomatic the patient is, we should be more aggressive with the atrial fibrillation because it tends to worsen the heart failure in a kind of downward spiral. So I think that the push in the next 5 years will be earlier and earlier aggressive control of atrial fibrillation, and possibly leading up to ablation, which is a catheter-based procedure for atrial fibrillation. So that change is probably coming down the pipe, but I think to answer that question in summation would be like this. Yes, there is a relation. Atrial fibrillation patients are more likely to have heart failure episode, and it can be from a weakened ventricle where the function is below 40%, but it can also be a normal ventricle that's going so fast that there's not time enough for adequate filling. And that we term still diastolic heart failure. So absolutely, atrial fibrillation causes heart failure. The reverse, though, does heart failure cause atrial fibrillation, is much less true. It does occur, yes, but there is not a so solidified connection. And I would definitely want to tell that person that I think that if you had heart failure first and late in the game, years down the road, you develop atrial fibrillation, you want to be as aggressive as possible with that atrial fibrillation, because it can worsen the heart failure long-term.
Great, thank you, Dr. Foster. Next question, will high cholesterol cause heart disease?
So the answer is no. High cholesterol will not cause heart disease. There are lots of patients with high cholesterol that do not have heart failure because of that. However, there are patients that have high cholesterol that has thus been one of the causes of coronary artery disease. And that is the biggest cause of heart failure. So what I would caveat that is to say, high cholesterol, high triglycerides on their own, by themselves, do not cause heart failure. There needs to be other contributing factors, and then the development of coronary artery disease for the patient to then go on and develop heart failure because of the coronary artery disease. I would also say to that person, just because I'm telling you that it doesn't cause heart failure doesn't mean it's not worthwhile to treat. because if you don't jump on cholesterol in the right person, cholesterol will absolutely lead to a problem. So long-term, you're looking at coronary artery disease. You may be talking about vascular disease in other beds, such as the lower extremities, the arteries going to the kidneys, and arteries within the neck and arteries to the brain. So we may not be talking about cholesterol leading to calcium deposits and heart failure, but we may be talking about cholesterol leading to deposits in the brain and the neck arteries leading to stroke, which is a big deal in and of itself. And there's also good evidence that elevated cholesterol in and of itself is part of a syndrome, the metabolic syndrome, which is the patients that have very elevated triglycerides, increased waist circumference, elevated blood pressure, and low high density or protective cholesterol. And those patients are going on to develop both diabetes and heart disease at a higher rate. So I would tell that person, caution to walk away from this with me saying, yeah, cholesterol doesn't cause heart failure, but it's the constellation that comes with the cholesterol problem that worries me long-term for patients.
Okay, great. And I just see 3 more questions, so we will finish with these. We have one attendee who says, I'm 72 and have heart failure. The only symptoms is shortness of breath while on slight incline or climbing stairs. Will this go away with medication?
Yes. So the 2 things I would say help the most with the symptoms of shortness of breath are, number 1, the right mix of diuretics. So the right mix of diuretics in a patient will improve breathing. It will improve sleep. It will improve their quality of life, because then they know when they can leave the house, when they have to stay at the house, they can alter that diuretic regimen a little bit. But I would also say that in the right patient that's motivated, cardiac rehabilitation is a way that they can improve their exercise capacity to what they want, because you're never going to push yourself beyond a certain limit that you fear in, outside of the doctor's office or outside of a monitored environment. Patients just have a tough time jumping the mental hurdle to push themselves more when they experience shortness of breath, because they're worried, and it's understandable why they're worried. But I would say, yes, you can get to the point where, you can walk up the hill without shortness of breath. It just involves patience and the right mix of medications. Okay. And you may need at some point to consider cardiac rehabilitation, because then they will grade you up and push you beyond that point at which you feel shortness of breath and which you fear to go beyond.
Okay, great, thank you. This one says, if due to other factors that have led to ejection factor very low, less than 40 or more, but through treatment that now it is higher than 40, are these still considered to HF patients?
Let's look over that question again.
It's there in the question and answer. If due to other factors that have led to ejection factor very low, less than 40 or more, but through treatment that now it is higher than 40, are they still considered, I guess, to be HF patients?
Oh, I think I've got this question. If the person, clears it up while I'm answering it, then just interrupt me. But I think what she's saying is, or he, if the function starts out below 40%, and then we go on medication and we recover above there, will the patient be considered a heart failure patient? And Unfortunately, yes, you're labeled. Um, you know, it's a label for life. Um, it will always mean that a doctor will look at you and unfortunately see that you need certain medications long term to maintain a normal function. And they'll always be looking at you to assess certain things and ask certain questions. So like the fluid questions, the breathing questions, yeah, it probably gets old answering those questions at every appointment, but that's the thing. They're trying to stay vigilant. They're trying to make sure they don't miss something changing where they may need to increase medicines or add additional medicines, you know, or maybe advise you about new medicines that are out there. I didn't touch on, you know, one of the new diabetic medicines, the SGLT2 inhibitors, but it's going to be part of our backbone of heart failure therapy. And so there's new things coming out all the time. And so, yes, you will continue to be labeled a heart failure patient. But what's changing about that is the label may go from heart failure with reduced ejection fraction to maybe heart failure with recovered ejection fraction, and then heart failure mid-range ejection fraction. And we're just teasing out, you know, in the last maybe 5 years, what medicines help which ranges the most. And I think we just know the most about heart failure with reduced ejection fraction, and we've tackled that, you know, hard. What we're learning now is that there's just so many different causes of heart failure with normal ejection fraction or the HFpEF patient that we need to tease out the cause first before we throw too many medicines at them at once.
Question for the evening, and I just want to thank you, Dr. Foster, for your time, and thank you everyone for attending today's webinar. And if you have any additional questions, you can feel free to email my marketing colleague, Champa, who's preparing to put her email in the chat box as we speak. You see Dr. Foster's contact information there on the screen. And then once you leave today's webinar, you will see a survey at the end of the presentation, and we'd appreciate if you could just take a few minutes to provide some feedback. And you will also receive a follow-up email within 24 to 48 hours, so tomorrow or Monday, with the link to view today's recording of this webinar. And on behalf of Inova, thank you for joining us today, and I bid you a very, very good evening. Thank you, everyone.